All right. Now we are going to go over basic concepts of decalcification that we're going to use also when we work in the growth room. So I hope that you will be able, after this mini lecture, to define decalcification, understand the procedure that you have to follow to decalcify a piece of bone in the growth room, and explain different methods for decalcification. The first step in your knowledge is to have an idea what kind of bone is in your hands to be decalcified. So it's not the same to have cortical bone versus cancellous or trabecular bone. Cortical bone is made of osteocytes surrounded by a compact matrix made of collagen 1 and calcium in form of crystals that we call it hydroxyapatite crystals. I don't know if I pronounced it correctly. So this cortical bone is present in the skull, in the cortex of the long bones, and is a strong, very compact, very hard bone that is going to take longer to decalcify. On the other hand, if you have a piece of bone that has trabecular bone is more spongy, has much more delicate arrangement of, and consists of trabeculae that are thin partitions of bone that make spaces in between those partitions, and those spaces are filled by bone marrow. And the best example of trabecular bone is a vertebra, a piece of sternum, and also the bone marrow biopsies that we usually receive in heme. Although the bone marrow biopsies are going to have a double type of bone. It's going to be cortical bone in one portion, and then cancellous bone in another portion. So the first thing that you are going to need to do is to allow this piece of bone to fix with formalin. Bone specimens first should be, your section should be fixed in formalin. If the bony tissue or the bone specimen is big enough that you may need to use the saw and cut it in 3 mm slices, you may need to do that first. And as much as possible, avoid the sawdust using a brush after sectioning. We are going to practice this first step in the growth room in the first lectures, the first 2 weeks. One of the lectures are going to be, or the sessions are going to be, how to use these different saws that we have in the growth room. After you obtain those thin slices of bone, it's important to fix the specimen prior to the calcification. Otherwise, if you throw the piece of bone inside the bucket with the decalcified solution, you're going to macerate the tissue, and you're not going to be able to see any histologic details under the microscope. For that, you're going to transfer your piece of tissue in a new container, of course, with a double identifier, your initials, the date and the time that you put it in formalin, and the date and the time that you put it in the first decal solution, and then if you change the solution, how many times, the dates and the time. This is the proper way to do it. Now, let's pretend that it's Friday and you are putting a piece of bone in the calcified solution. You are pretty sure, because you are confident, that it's going to not to be dissolved completely, that piece of bone, by Monday, because you use a slow decalcifier. But on Monday, you are not going to be on service anymore. You're going to go to CP or blood bank or microbiology. You're not going to be anymore in the growth room. So proper handoff of the specimen to the resident who is taking over the subspecialty is one of the steps that you are going to learn how to do it. by written email or in person. And if there is no resident that are taking over the subspecialty, the bone soft tissue subspecialty, you may need to transfer to do the proper handoff to the PA supervisor. But this as aside, we're going to talk about more about the handoff specimens. You are going to identify the container and to document how many times you change the solution, and for the person who is taking over the case to be aware of. Poorly fixed specimens become macerated and stain poorly. We said that. Formalin should penetrate the bone first and then the decalcification solution. So allow 24-hour fixation for compact bone. For some sources, books, resources, sometimes is 48 hours, but we don't use this. So when you cut your piece of bone, the saw certain saws, the most frequent saws that we use, are going to leave sawdust. We call it sawdust because they're going to leave speckles of bone in between the real specimen. So make sure that you brush appropriately, and we are going to practice this in the future, avoiding the sawdust in the specimens. Why? Because this sawdust is easily confused with bone necrosis under the microscope, and we don't want to overdiagnose bone necrosis. Let's go to the proper decalcifying agents. How are you going to use the different decalcifying agents that we have in the growth room? Decalcifying agents can be classified as strong mineral acids, weaker organic acids, and chelating agents. The strong acids are basically hydrochloric acid or a combination of hydrochloric acid at 10% and nitric acid. These are, as the name implies, strong acid. That means that if you remember from chemistry, organic chemistry, strong acids are completely dissociated in aqueous solution. That means that all their protons or the positive charge are separated from the molecule and binds to the water. So they leaves the acid with a negative charge that will be available for the calcium, which has a positive charge to bind to. And so that is the basic principle of decalcification: extract the calcium from the bone. And the way that these strong acids does it is binding the positive charge of the calcium and separating the calcium from the hydroxyapatite molecule in the bone, inside the bone. So it's a very fast method. It's the fastest that we have. But unfortunately, because are very strong, it can macerate the tissue. As you can see here, all pink. You don't see anything more than something that looks like trabecular bone without any nuclei inside or any bone marrow nuclei. So this is a macerated, over exposed tissue to the strong acid. We don't want this. So that we have to be monitored closely every 2 hours or every hour, the piece of bone, to make sure that we are not over macerating the specimen. Is the most aggressive form of decalcification, and in our lab is this solution is called Surgipath Decalcifier 2. It comes in gallons, and you will find in the growth room, and use it especially for cortical bone and strong compact bones. The weak acids, as the name implies, are not completely dissociated in water. So some of the molecules are going to be dissociated, some others don't. and the prototype is the formic acid at 10% solution. Is weaker, but is slower but gentle. So that is the ideal acid to put a cancellous bone, for example. And it's less likely to interfere with the nuclear staining, so we are not going to be macerating the tissue if we leave it, the specimen a little longer with weak acids. And in our lab, it's called Sorgipath, the decalcifier #1. The chelating agents is the EDTA. We don't have yet EDTA. We have it, but we don't use it routinely. It's very slow. It works not as a agent that binds or give protons to the solution, but works it's a complex molecule that entraps by covalent bonds the calcium molecule, and it doesn't allow the molecule to return to the bone. So it's very slow, it's pH dependent, and the basic use of chelating agents is when you have a piece of bone that absolutely necessary, needs preservation of the antigens in the surface of the tissue, because it's going to need, for example, molecular studies or more sophisticated studies that with weak acids or with strong acids is not going to be possible to perform. But we don't use it currently in the lab. We are in the process of validating the EDTA just for bone marrow biopsies, especially when they need molecular studies. When you put the acid in a container, properly identified, and you put your piece of bone, let's pretend that this is your piece of bone, and you put the decalcifier agent. How much decalcifier agent you have to put? Well, the volume is approximately 10 times the volume of your piece of bone. So make sure that you put 10 times, because the concentration of the active agent is very important. It is inverse to time. We need to frequently change the solution to allow the solution to be active, because the acid, what it does is to entrap calcium in their molecules. So at one point, this solution is going to be saturated with calcium and is not going to work anymore as entrapping positive charges. So we need to extract the piece of bone, discard the solution, and put a fresh solution again to have the same results, or the further results. Another factor that influences the rate of decalcification is the temperature. We don't use heated agitation in our lab. Exceptionally we use, but know that increased temperature will speed up the decalcification rate. It's for your own knowledge. And sometimes when we have a stat biopsy, we can use a slightly increased temperature, 60 degrees Celsius, just to accelerate the decalcification process in the afternoon. All of these methods will have a deleterious or undesirable effect. If you increase the temperature, you are going to be able to accelerate the rate of decalcification, but also accelerate the rate after the tissue macerate. So make sure that you do it with you have a person or someone else that has enough experience on this at the beginning. Another important factor is the agitation and fluid access. So if you are in the grossing table, you put a piece of bone beside you, properly labeled in a container, and you are taking care of other stuff, just remember to gently agitate the container. So that may increase the rate of decalcification, and all the you ensure that all the surface of the specimen is accessible to the acid, and it can be decalcified faster. So as I said before, sometimes it's difficult to remember, but Decal 1 and Decal 2 solutions are the two solutions that you are going to have in the gross room. Decal 2, because it has the highest number, is the stronger acid. And the vendor says that you can use it up to 20 times the volume of the specimen, but we use it with 10 times the volume of the specimen with very good results. And it has to be changed every 2 hours. You can decalcify very fast a piece of cortical bone in the afternoon. On the other hand, Decal 1 is a smaller number, so remember that it's a weaker acid, so it will take a little more time, and it is specially designated for small specimens, delicate specimens, or delicate decalcifications. And small specimen can be done, for example, a bone marrow biopsy in 2 to 4 hours, a needle biopsy in 1 hour. So it's very efficient. So what happened after you have decided that your tissue is decalcified enough? You are going to take the cassette out of the solution and thoroughly rinse the specimen with tap water, under the tap water, running water, especially if you are using the strong acid, because hydrochloric acid makes a compound with formalin. You may need to put back the cassette back into formalin for processing. So if you have residues of hydrochloric acid, that is going to form this compound inside the container with formalin, and this compound is carcinogen. I cannot even pronounce that compound, sorry. So one of the most important or difficult at the beginning steps is to decide, well, is my tissue properly decalcified now? Can I take it out from the decalcified solution? Or should I still continue decalcifying the specimen? And that is called the endpoint determination. You are going to determine if the tissue is completely decalcified. One of the most easiest ways to do it at the beginning, if you don't have enough experience, is to, because we have an X-ray machine for breasts in the gross room, you can X-ray the piece of bone at time 0 and every different hours, 24 hours, 96 hours, or more hours, and you can see the difference in decalcification. So see how the white stuff is gone with the time. Well, that is the calcium that is dissolved, or this is the close to the near very endpoint determination at 144 hours. But this is a big piece of bone. Also, there are articles that talk about the different decalcifiers, but this is just only to show you the way that we determine when you don't see any more white stuff in the bone. It means that it's completely decalcified. Look at how many hours and days it takes for a cortical bone to decalcify with EDTA. That is why we don't use usually EDTA for everyday decalcification. But if you don't have the Faxitron, sometimes some people put a needle through the piece of bone. If the needle penetrates the bone, that means that it is soft and it's decalcified. But I highly recommend this more accurate way to do it. Once the endpoint has reached, you have to rinse the cassette. Please rinse through running water and then place in the container with formalin for processing. What happened if you were wrong? It was under decalcified and you still have calcium in your sections. The histology lab is going to get you a poor quality section. But don't worry, there are solutions for that. Histology lab has a process that is called surface decalcification. They can put the block with some decalcifying solution in a Petri dish for a while, for some minutes, and then they can take a section, a better section, better quality section. So don't worry if you didn't hit the endpoint determination at the beginning. There are ways that histology lab can give you a good section. What we cannot reverse is if you macerated or over macerated the tissue and you went beyond the endpoint and didn't take the tissue on time. In summary, make good thin sections without sawdust, formalin fixation in an appropriately labeled container. If you want Faxitron, the specimen at time 0 and every 8 to 24 hours for big specimens, appropriately choose the decalcifying according with the size and type of the specimen, use the adequate solution and the adequate volume of solution, shade the container if you can, and determine the endpoint and stop immediately with running water. We are going to practice this in the future. Don't worry. This is just an informative mini lecture for you to have an idea. And if you have any question, you can email me. Thank you and see you soon.